Good morning, everybody. This is, it's very good of our, to have our visitors here today, because this is a relatively short board meeting with only a few items, important items, but only a few of them. If we first of all start with the minutes, do colleagues feel that the minutes can be taken as read, or are there any comments on the minutes? No, well that looks like there's a fine, in which case we can go straight into David's report, which, as you've seen from the papers, includes, I think, the monthly report that the executive team now receive, and that was one of the, I think, recommendations from the board, that it would like to see the monthly report. So the monthly report is now here. David.
Michael, thank you. Michael, thank you. Good morning, everybody. So this report is in two halves. The first half is really an update on performance, and the second half is sharing with you the announcements which have been made since the election in May, which have an impact or a direct relevance to CQC. Provide an opportunity just to update you on what we are doing to engage with those announcements and take them forward. If I may, Michael, I'll add one additional issue to that list of announcements, which is the Royal College of General Practitioners letter to the Secretary of State yesterday, which arrived after this report had been drafted and circulated. So I'll do all of this quickly because I think this is, I hope, self-explanatory. So on the performance reports, the April report is attached to Annex A. It is very much, as you've already indicated, the report that comes to the executive team on a monthly basis. It's slightly reduced from that, but it is effectively that report. It is the report for April. It is month one, and I think it's too early to identify any trends in this current financial year, but it is a statement of performance during the month of April. I think the actions that we identified the previous month in relation to the year-end report about concerns which have been outstanding for over a year is the point that I'm trying to draw out in paragraph 1, and that work continues. So the activity that's driving colleagues in the executive team in their own management meetings is that which was in that last report about how we get on top of these issues where there have been concerns for more than 12 months. And as we've tried to outline in that paragraph, we're now clear about those locations, those which have been inspected, those which have not taken place, and what the next steps are in relation to that. So we'll continue to update the board in these monthly reports, and particularly in the quarterly reports, and the executive team is paying particular attention to those issues as we move forward. The remainder of this is an update on activity and performance. Colleagues in HR in the recruitment team continue to perform well, and the figures are there. 429 offers made, 362 to inspectors and 67 to managers, with a further 94 appointable inspectors who are currently being matched and have not yet had an offer letter. I have to say that's very good progress, and as the next paragraph on the academy indicates, some 243 at the time of the report have now done the 6-week role-specific induction. So that means of that recruitment activity, 243 are now through that and are beginning to take up their new roles. They may well be working with a buddy or working alongside somebody as they progress that induction, but progress is being made. In relation to Mike, Andrea and Steve's directorate, the figures are there in terms of performance since October in terms of new inspections undertaken and rating reports issued. And I'll not repeat the figures. For Andrea and Steve, the numbers speak for themselves. Paragraph in relation to hospitals is produced slightly differently because the volume is less, but we've captured that in the table that's on page 4. On safeguarding, the third meeting of the committee, which Sally Warren now chairs, continues to make progress in terms of reviewing policies and approaches to safeguarding. The committee also picked up on the lessons from the Kate Lampard report, which had some publicity recently following on Jimmy Savile, and we are also looking at how we can, as CQC, learn the lessons from serious case reviews and safeguarding adult reviews that CQC takes part in as well. What are the lessons for us as the regulator from that activity? So I think that work progresses well under Sally's leadership and having the membership reinvigorated. If I pause at that point, Michael, in terms of the performance activity, and if colleagues have any questions, then Andrea, Mike and Steve can answer them.
Okay.
Yeah, I've got a comment and a question. My first question is very simple. Just wondering when the staff survey is going to be done and published. I have a sense that it should be about this time of the year. So it'd be useful just to know that. And the other sort of comment really is I was looking at the registration bit of the April performance report, and we've got performance indicators, and I think it's really important to have performance indicators. But what we have here is that we haven't quite hit them, and the reason is because we've had a number of complex applications which challenge the new models of care approach, which specifically residential services for people with learning disabilities. Now, I think actually that's a good example of when it's okay not to hit a KPI, and because if we had hit it, we might not have done such a good job, and it's important we get it right. So. Just to say, I think that's actually a good thing, and it shows that you don't need to be kind of slavishly attached to performance indicators and targets. You need to look at it, but also you need to go beneath it as well, because to me that is, I'd rather miss the KPI and do a better job.
Just on exactly the same point, I wondered whether it wasn't so significant that we almost needed to, it would be helpful to know how many cases, registration applications, should be in effect taken out of the general figures and dealt with and seen as being a separate category. So a deliberate separation because they require special attention.
So Andrea can do the difficult one, and I'll do the staff survey. So it goes out in the next few weeks, 19th of July, and it will go out for 4 weeks. New contract with a new provider. They were at the executive team meeting on Tuesday of this week and laid out that timetable. Their analysis will come back 4 weeks after the closure in August, and are we bringing it to the September board meeting? Top level analysis.
Our hope is very much to bring the top level to September, and then obviously the more detailed work through will come to the New People and Values Committee.
And I think there's been some exploration of the last survey, and there's a new location on our external website being created under the heading Transparency, which has the past 3-year annual surveys published in full. So they're now published and available to anybody that wants to get access to them, and we'll do the same when this one is through as well.
Thank you very much for the questions and comments, Kay and Anna. I think that you're right, Kay. We need to do a good job. I mean, I think there is also
a value in us trying to do that in a timely way, particularly because this is going to have an impact on the provision of service. So I think it's interesting what you say, Anna, because I thought that a little bit about the point that we've made in the report around where we're refusing a registration. That obviously the kind of, the timing that takes and the completion of that is going to take us, inevitably probably beyond the KPI. So I think that it may well be worthwhile having a kind of conversation with Paul and his team in terms of what further analysis can we do to drill down into this, because I wouldn't want to change the picture quite yet before understanding properly. I'm seeing Paul nodding at me, the hawk on that side of the table and the dove on this one around these issues sometimes. But I wouldn't want us to kind of automatically say, yes, we can change this, because actually 50 working days is 10 weeks, and that is actually quite a decent amount of time for people to wait for things. But it's probably much more meaningful for us to see what we can find underneath these figures, which say how many of these do relate to particularly difficult cases that we've had, either in terms of the level of scrutiny required, or that they've led to a significant level of challenge because of the decision that we've made, and see whether there's some way that we can represent that information. And a little bit like we've done on the safeguarding is say, let's see what that says before we change any of the targets that are associated with it. And I hope that you thought that I answered that question appropriately, David.
Trouble Andrea with the supplementary. Just in relation to those that are refused, it seems to me, firstly, that the numbers we actually go through a registration process, it's useful for us to know, but the impact is on those that we register as against those we don't. And I think it might be helpful, to me at least, if we could have a little information sometimes about why they're being refused and what the impact of that is on patients or service users, simply because the impact is not always just about protecting people from an unregistered bad service, but it's also, if the service isn't there, then patients have been prejudiced by the lack of availability of it. So it seems to be that we ought to as a board, be monitoring what the value is of the registration process that obviously we're legally obliged to do.
I think that's really helpful, Robert, and I'm sure that we can do something probably on a periodic basis in terms of bringing a report maybe as part of David's Chief Executive report that gives you a little bit more flavour to what we're doing around registration. And it's also worthwhile flagging up that one of the things that we're working on at the moment is to produce a document which we will be calling a Fresh Start to Registration, trying to pull together all of the work that we've been doing over the last year around our registration improvement project, both in terms of getting us ready for the new regulations that came in on the 1st of April, trying to speed up our efficiency and effectiveness in the way that we deliver registration, but also giving ourselves an eye to the future around what do we need to do in registration to enable us to cope with and not be a barrier to the new models of care that may well be coming through, particularly integrated models of care. So that's a piece of work that's happening, and again, it might be worthwhile tying those two things together.
Andrea, two quick questions from me. One is, I was just very surprised, and I've been reading this page a number of times, but it struck me, perhaps because this was a shorter pack, I actually focused on it. The sheer number of registrations I found surprising, because effectively 22,000 in adult social care, nearly 3,000 in hospitals, and 11,000 in primary medical services. I mean, that seems to me like a huge number. So I just wondered what was being registered that led to this very significant number. And the second question was actually related to the draft NAO report, when I thought they made an interesting point that registration should not be seen as a CQC seal of approval. It's something different, and I think, your thoughts on, maybe not at this meeting, but on how we communicate what registration actually is. Sounds like it might be helpful.
Thank you very much, Michael. On the huge number, we're including all registration activity here, so that it's not just new registrations, it's obviously variations, and it's registered managers as well. So I think that kind of, again, if we're going to do something that gives you a bit more of an insight into registration on a periodic basis, then I think that we can probably break that down and show you those different types, which will help to give an explanation to the numbers. And certainly in terms of us being clear about what registration is and what it is not, what it does for us and what it does for the people who are providing services and those people who are using services, is something that I think that we can set out quite clearly in the Fresh Start for registration, and use that as an opportunity to kind of clarify those messages for people, and then give us all a baseline to explain that to people in the future.
Thank you. David.
Thank you. This next section is really about, I've classed it pretty broadly about announcements. I think there's two components to this. I think there's some announcements which are about clarification and simplification of the architecture moving forward, bringing Monitor and the TDA together, I'd class under that. And then I think the vast majority really signal an intention to focus on resources, particularly in the NHS, and a tighter grip on resources, to use that phrase. So I'll go through them very quickly, Michael. As colleagues know, the Secretary of State has asked CQC to look at the use of resources as part of our assessments, and that work is now underway, and Paul and his colleagues, working with Mike and his team, will actually take that forward. That links in a significant way to the work that Patrick Carter has been doing on productivity. Patrick published an interim report a week before last, I think it was, in relation to some high-level findings based on the work that he's been doing, which flags significant variations in the way that spend takes place across the NHS. He drew attention to procurements, but particularly drew attention to issues around staffing, which are significant. Paul, Mike and I spoke on a teleconference with Patrick Carter earlier this week, and I think Paul's colleagues have now met Carter's team, and we've got a further face-to-face meeting coming up with Patrick in next week, I think it is, to actually take this work forward and just make the connections between his work and the ask that the Secretary of State has made. Links also the issues on staffing to the decision of NICE to suspend their work on safe staffing levels. Colleagues that get these alerts from the Health Service Journal will know that some further work was drawn attention to yesterday in relation to staffing, which I thought was interesting in the way it was reported, because it strikes me that a lot of what the inspection team are doing and looking at things like trips and falls, etc., and staffing levels is exactly what our methodology was is based on. But we await the work that Jane Cummings is doing, and we'll work with Jane and her colleagues in relation to that. The other announcement that was made on the 3rd of June was about the success regime. The significance of this is it's looking less at individual organisations and more at systems, and is taking a broader based view of how success is created, and 3 areas have been identified to focus a success regime. There is an overlap with the work that we do, clearly, because many of the institutions in these areas are organisations which we've expressed some concern about, and indeed are likely to be in special measures. So an important piece of work for us to be engaged with and to follow. Bruce Keogh published a couple of weeks ago the outcome of his work in reviewing current waiting times and the referral to treatment time. So there's one measure of this now that people are working to. We've also drawn attention to, and this links to the issues about NICE agency, the CARTI work on agency and staffing. The Department of Health announced a financial controls package, which is really a cap on the use of agency spend in the NHS, which is of this general piece of tightening around finances. The Monitor helped Foundation Trust to adopt best financial practice, I think is connected to the CARTI work, the agency caps, etc., etc. And we draw attention to that in this report. The vanguards have been extended to cover urgent and emergency care, signalling that this is a vehicle for looking at different models of care and different ways of organising care. And then the King's Fund have been asked by the Secretary of State to look at clinical commissioning groups metrics, which I think is also signalling that there's a need for the system more generally, including commissioners, to focus on performance and improving performance. Slightly differently in theme from those announcements, the GMC have published their national training survey, which there's some high-level detail in here, which I think is important material showing how supportive training environments are to the doctors that are working in those environments. We know from Mike's work the importance of how well led an organisation is and how they attend to these issues. This is a critical ingredient in the success of those organisations. So I think this is an important survey, which is why we've drawn attention to it in this. Some good news is the staff of CQC that were recognised in the Queen's Birthday Honours. I don't think we can claim credit for Regina Alinar. I think she's in about her 4th or 5th week, but she's a paralegal in legal services who has done some victim support work in her own community in Haringey. She lives in the Tottenham area on victim support, where she's volunteered on victim support, and I went to congratulate her. I said, "Why do you do this?" And she said, "I wanted to put something back into the community that I live," which I thought was a fantastic response, and it's really, I just think it's what the honours are about, is about recognising those people that put a contribution into their community. So I have to say I was very pleased and delighted for Regina. Slightly at the opposite end of the extreme, John Milne is recognised for his career in dentistry and his contribution to dentistry over best part of 30-odd years, I think, and many of those occupying national leadership positions. And John is now working for us as a dental advisor, and I have to say he's performing very well and was recognised. And then James Titcombe, who probably needs little introduction, was awarded the OBE for his contribution to patient safety, which I think represents quite a significant journey for James, from the father of a child who died in 2008 to a role where I think undoubtedly has influenced national policy. And I think it's a really good and interesting spread of people that make contributions in different ways that has been recognised. So it's nice just to pay attention to those colleagues and congratulate them on, not just on the awards, but on the work that they've done that has led to the awards. So I would draw attention to that. And then finally, Michael, if I may, just to mention our public board meeting, I received a copy and a courtesy telephone call from the President of the Royal College of GPs on Monday in relation to the letter that they sent to the Secretary of State in relation to their workload and their concern. And that letter included a request to pause and review our inspections of primary medical services, and it did ask for a pause in routine inspections while that review takes place. Our response to that has been to emphasise that our purpose in assessing the quality and safety of services is so that people who are using those services, patients, can receive some assurance about the quality and safety of those services, and that we would continue to conduct our inspections. It is essential, I think, we establish a baseline and we complete our inspection programme and go through the inspection programme. To date, 1 in 7 of our inspections have resulted in us expressing some concern about the quality and safety, and has led to us taking action in relation to this. So what we've found. Our concerns around safety have been about vaccines, about appropriate prescriptions and medication, about early diagnosis, etc. And these are the classic issues around safety in primary medical services, and will continue to be our focus. The Secretary of State has also issued a statement in relation to inspections carrying on, which is supportive of the work that we've been doing. I think, Michael, you and I have mentioned this. The thing that's important to emphasise is that in saying we are acting to support the interests of people who are using services, patients, residents in care homes, etc., this doesn't mean we're against those people delivering those services. And I think picking our way through how we can call out the quality of services, say what's outstanding and good, and say what is of concern, and that being used in a positive and constructive way to drive improvements, is really the tone that we're attempting to set here. So we'll continue to work with the Royal College and the BMA, who've also joined this. We are later today going to spend some time looking at our strategy over this next period of time, and I think that provides us an opportunity to begin to set out later this year how we intend to develop regulation over this next period of time, and I think that will allow us to address some of these issues about not only what we do but the style and tone within which we do it. So if I pause there, as I say, there's a lot of updates because it went very quiet during the election period, and then there's been a burst of activity over the past few weeks, which we've tried to capture here. Not necessarily with a view to opening it all up. Much of this is work still in progress. Our use of resources, we're at the beginning of that, and there's very little content to report, but I hope that gives the board a sense of the activity that colleagues in ET and predominantly in the strategy and policy unit are now beginning to pick up with a view to making clear plans for how we take this forward and how we work with other organisations. Thanks, Mike.
Jennifer.
So thank you. Just to add an extra bit of news is that in addition to the King's Fund being asked to look at the CCG metrics for quality, the Health Foundation have been asked to look at GP metrics for quality, and we've accepted that. We're going to be doing a stock take, which will complete at the end of September, and we'll be working with all relevant stakeholders, CQC, BMA, others, to go through the metrics that exist to see how far meaningful, credible metrics can be used for various purposes, including informing the public and also for learning, continuous learning. So we're happy to take that on, and we'll be obviously in touch and working fully. So that's point one. Thanks. Point number two is just on Carter. Lord Carter's report was very interesting. He concentrated, just as you said, David, on procurement, but he also procurement and staffing. So cost management, actually. But he also signalled that the next phase was going into a different phase, which was also looking at processes of care. Now, not much was said about that, but I'm kind of putting that together with the contract let by TDA to progress lean thinking across clinical pathways in 5 trusts. So I think there may be something for us to think about this afternoon about clinical pathways and productivity. let alone quality, which is what we normally focus on, which is really getting into clinical processes of care, which I think is more our domain than a sort of audit use of resources domain, if you see what I mean. So I think that's quite an interesting, and that also links ultimately, the next step on the path is new models of care, I think. I can explain more of this later. So I think that's something for us to think about vis-a-vis the future. And the last thing I was just going to add is that clearly Monitor TDA, early stages of discussions about merger, but also on the table here is a discussion of what their role is in improvement of providers. And I know that's something, do you remember our board to boards? That was a real gap in the system. There is no obvious improvement strategy, if you like, not just for failing organisations, but also people who are organisations in pre-failure and also organisations that are okay. How might they best improve? So there's a lot of thinking going on in TDA Monitor, I think, at the moment on that issue, and it also relates to the Smith review, and it's also indistinct yet as to kind of what this improvement function is going to be and where it is going to be.
Thank you. Oh, sorry, Robert.
I just about the, excuse me, the question of staffing. Given where we are now, which is that the work of NICE has been suspended, but they might be asked to do some more. The Chief Nursing Officer is formulating proposals for continuing research in this area. Do we have any idea of the timescale within which any product is going to be produced from research? And given what appears to me, at least, to be a degree of uncertainty that exists at the moment, what is CQC able to do in terms of inspections and so on about its assessment of the adequacy of staffing? In other words, does it do so? And in the I mean, the guidance for hospitals is still there, so that's one tool. But in the rest of the bailiwick, there doesn't seem to be very much, and that was what was being developed. And so really what I'm asking is two things. What is CQC doing going forward about this? And secondly, is what contribution really can we make to inducing some more certainty for those areas where clearly people have not much guidance to go on?
Robert, I don't have any ideas on timescales, but I can tell you what we're continuing to do in terms of our inspections, and in many ways that hasn't changed. We will always look at staffing levels in all of the services that we go into, because we know that staffing can impact on safety and the caring domain, so it would be perverse not to. When we do look at staffing, we take a rounded view. We observe staffing levels and the impact on patients on the ward. We talk to patients, we talk to staff, we look at what incidents have been reported, we look at whether there have been slips, trips and falls. In many ways we do exactly the same things as were being reported yesterday in the leaked report. Not everywhere has necessarily as high quality data as was being reported yesterday. But we take a rounded view, and we also look and see whether staffing is on the risk register. In many cases, the organisations themselves have identified that staffing is a problem. So we take that rounded view. We then take a view on to what extent that is impacting or likely to impact on safety of patients, and we report on that. So I don't think this will change our view. We would not ever rely on a single figure of 1 to 8 or whatever to make a judgment. We may also look at the rosters. We do look at the rosters, and we look at them, both the rosters for the previous month and their planning of rosters looking forwards. So that can give us useful extra information, and can just be a check that they haven't staffed higher on the days we happen to be there than they would have had over the previous month.
Okay.
My question is about the vanguards and the urgent and emergency care. And I wondered if they were including mental health in that, because the philosophy behind them suggests it should be, but I'm not sure if it is included. And it would seem, the report that we received last month on mental health crisis care that we did would seem very relevant.
So the proposal that went out for applications for this this Vanguard, if I remember rightly, starts by saying that the mental health crisis care is a fundamental component of the overall emergency system. And I raised this with the New Models of Care Programme Board. As with all the Vanguard programmes, they're not trying to find new models of care for all the different new models of care in the country that might exist. They're trying to look at how we could develop at scale very specific ones. So there was a desire for them to be focused as well. But I think the key thing is to look at what comes back from the applications rather than overly prescribe what must or mustn't be in them. And that's a process that will now be followed.
Okay.
Good. I think we can now move on to the handbook on how we're going to inspect 111 services. I think, Paul, I thought this was an excellent handbook, by the way. But the board does have to approve its publication. So perhaps you could just briefly introduce how we are going to inspect, but assume that the board has read the handbook.
Thank you. So the board has seen a number of handbooks, and we're coming towards the end of the publication of the first set of provider handbooks. There are one or two others, including substance misuse, still to go. It is worth reminding, in the paper, there are currently 18 providers of 111 telephony-based services. So this is a relatively small sector by volume of providers, 10 ambulance trusts and 8 out-of-hours GP providers. The approach, and we have tested this through pilots from February to April and consulted, is as set out in the paper. It's a telephony-based service, so it's not a question of going to visit the individuals as they're receiving care. They're very much on the end of the phone. But it does draw out a couple of points. One is how we would observe direct care. The other is the issue of timescales for announcing our inspections. And we've had a conversation at board previously about the observing care piece. We think there are a number of ways that we can observe care, including listening to live calls where that's appropriate, and where the inspectors and special advisors are trained to do so, and also listening to a sample of recorded calls. The option is always open to us to do the mystery shopping that we've talked about in the past, but it's important to remind the board that's a power we only have under the RIPA legislation if all other avenues have been explored and discounted. It's not something we can just choose to do, and we would require specific approvals to do it. And we have a piece of work underway on our overall RIPA powers under development. So the plan would be to publish the handbooks following the board meeting and complete the programme of 18 by the end of September 2016. In parallel to that, there's a piece of work going on to test our approaches in a local area to overall urgent and emergency care, which is mentioned in the paper and sort of alludes to Kay's question. But that's the summary of what we'll do.
If colleagues got questions for Paul. Robert.
Sorry, presumptive, putting my microphone on. I thought, too, this was excellent and very, very clear, if I may say so. I just have one question about something that slightly puzzles me, which is the monitoring of calls during an inspection, where it is said that normally that will be done, in effect, by only listening to the handler's side of the call, not both sides, and only in certain circumstances would that be the case. Really, two questions. One, for myself, I just find it slightly difficult to understand how one can monitor the efficacy of a call without listening to both sides of the conversation. And secondly, presumably, even if we're only doing that on an infrequent basis, some sort of warning has to be introduced into the phone call when someone calls 111 that their calls are monitored, so, which is what happens when you ring any service centre. But it's really the which I didn't see it here anywhere, but it's really the first point, which is the approach. As to why we are as diffident. I understand the confidentiality issue, but I would have thought that's quite easily assured in relation to something that doesn't get written down and so on.
So I think the point behind it is people are calling 111 services in a moment where there's some level of distress or concern, and we don't want to get into a situation where unnecessarily we're causing any increase in that in that concern. So if we can do our jobs without having to listen in to the patient part of the call, which is, I absolutely take the point that there's a confidentiality both ways, but inherently more confidential as the patient is speaking, then we will do that. But it's important to say, as it says in the handbook, if we need to go further, then we can. It's just a question of trying to balance and be pragmatic about how we regulate without causing stress or concern.
All the calls are or should be recorded, aren't they? So they could be listened to retrospectively.
Yes, they can, and again, that's something we can also listen to.
Emma.
Thanks very much. So I was really pleased to see this elaboration of what we were going to do, because we had a good conversation about it last time, so thanks for that. But I just wanted to check, so in paragraph 23 we talk about using the telephony system as a way to signal to people that we want feedback on the 111 service, which I assume means using kind of recorded messages as people are in waiting mode and so on. And so exactly to your point about people being in some degree of distress when they're ringing at 111, I just caution against using that in a way, and or at least to be really careful about the way that we whether we suggest that, because one of the things that I would hope we would look at is the quality by comparative terms of the holding patterns that people are put in when they ring 111 services. So nothing more distressing, actually, especially if you're in than being put through a series of triage recorded messages before you actually get to speak to a person. And if you also have a message which says, and we want to hear back from you, and you're still waiting, then even worse. So just, I mean, I think it's an important thing to look at how the telephone system triages people and what it does as part of the quality assessment. But it would be a travesty if we just added to that without thinking about the implications.
Yeah, so that's absolutely right. I think the spirit of what we're trying to do there is give providers who, I think, inherently know their user services better than we will do from a regulatory position, the accountability for how they advise people that we want to hear their experience. And yes, just the act of having another 20 seconds before you can get through to anyone, that's not something we want to encourage at all.
Jennifer.
It looks very good, thanks. Just the providers of 111, do they all use the same algorithms, or is that something that we need to check as well?
They do. They all use NHS pathways. They're all expected to use NHS pathways, as it's called, which is the clinical algorithm. And it's a part of effectiveness. Absolutely, it's whether any provider is complying with the agreed standards, the first Chloe in effectiveness, that would absolutely come into it. But they certainly they'd be in breach of their contracts if they weren't using the algorithm.
Any other questions for Paul? I have a question, and it was raised, or it occurred to me as a result of Bruce Kehoe at our dinner last night, which is, although this happens to be telephone, it's in a way a sort of a move digitally. And I just wondered, not for today, but we are going to have to face up to the issue of how we regulate digitally provided services at some point, and maybe that'll be discussed this afternoon.
So I think that's absolutely right. We'll see it in these sorts of services. We know there are already digitally based general practice services on mobile phones. We expect to see more of these things, and we absolutely will look at it.
Any other colleagues? Okay, thank you very much, Paul. we can now move on to the two, the Regulatory Governance Report, Committee Report, and the Audit and Corporate Governance Committee Report. Lewis is taking over as the interim chair of the Regulatory Governance Committee, but as colleagues know, he sent his apologies today because I think it was his son is graduating from university today, so I think we have to accept that that's as important an occasion as a CQC board meeting, especially for the son.
And Lewis as well, I suspect.
Well, and for the father, but well, it's important for the son. The father is there. So. On the RGCs, if I may just sum up, I think the RGC has improved as a committee over the last 6 months. It's become much more closely involved in how our regulation actually takes place, and it's become much closer to the issues to do with regulation. And the paper itself cites, I think, a number of issues the committee has looked at. One is intelligent monitoring, which was touched off by GP intelligent monitoring, but the audit report covered all intelligent monitoring. And I think we were very pleased that Paul, there was no questioning of whether the audit report was right or not. The audit report and its recommendations were accepted, which was excellent. But we did say that we wanted internal audit to take another look, given that intelligent monitoring or the use of data, which is also, we may come to later, is so important for us. So I think the idea was that internal audit would revisit intelligent monitoring in, actually it was 6 months from the date of the committee meeting. Mike gave us an excellent overview of hospital inspections. And we also had, and I'm just going to link these, a meeting, one of our meetings focused on Hinchinbrook. And both of these committee meetings came to the view, but it's no different from Mike's own view, that our publication process needs to be made quicker. I mean, in the case of Hinchinbrook, the re-inspection took place before the first inspection report was published. So timing, is an issue. But as I say, Mike is absolutely conscious of this, and we have to balance timing with the need to accept that providers will have factual accuracy issues which we need to settle. And that really raised the second issue, I think, for the committee, is that our standards of evidence and note-taking, there's always room for improvement, because when we went through the Hinchinbrook factual accuracy report, many of the questions raised by Hinchinbrook were about can you prove this, can you prove that? So the need for better evidence, or maintaining, even though it's slightly bureaucratic and time-consuming, maintaining a better note-taking system was one of the points that the RGC felt needed to happen in future. So I think I would sum it up as a much improved committee. I think it's now in a position to give assurance to the board that for hospitals, which is the first of the directorates that the committee has looked at in depth, that we both have very good processes at the moment, and that the Directorate itself recognises where there's scope for improvement. Any questions on the RGC? Paul.
It's not a question, but to follow on from the point about the timeliness of reports, and it links to the timeliness of registration conversation earlier. The work that the committee looked at on the operating model, how CQC ensures quality in everything it does, has been progressing since the RGC conversations, and a big part of that is setting out clear quality standards that cover the quality of the end product as well as its timeliness and equally as well as its costs. And so that's something that we'll be rolling out over the course of 15-16 and helps us on both publication timescales, but also to Kay's original point on making sure that we're not sacrificing any one dimension of quality in the case you mentioned against timeliness. It's an overall perspective, just as we want to do for our providers.
Thank you. Paul, sorry, Anna.
Sorry, so this is not on the detail of the report, but I just kind of observed that, as you say, the role of the subcommittee has changed, perhaps clarified, but it also lost the values dimension, which has gone to the People and Values Committee. So, but when it was originally constructed, the membership was to reflect the original brief, and I'm just conscious that since the role has changed, as chair of that group, you were keen to offer an invitation to all the other board members to come if they wanted to, and I just wonder if that doesn't all taken together signal that perhaps you need to look at the membership of the subgroup to see who wants and or needs to be on it, because it might not be the right set of people from the board any longer.
No, I think that's a very good point. As Anna, rightly says, for the committee meeting at which Mike, we had a conversation with Mike about hospital inspections. I did invite, every board member to attend because, one of the reasons this committee exists is that we just don't have time as a board to look at some of these issues in the depth they require. But Anna's specific point about, should the committee itself or the membership be reviewed, I think is a good point, and I'll make sure that I raise that with Lewis when before the next committee meeting. So, if we can now go on to Paul's report.
Thank you, Michael. This report is produced, it's an annual report, and it's been produced to coincide with the production process on the annual report and accounts, which the last committee meeting spent much of its time on. And the fruits of that, the discussions are included within this annual report. But the annual report covers the year as a whole. And if I can skip through the introductory bit and move on to the main themes and conclusions and the specific items underneath there, I think those are where you see some of the flavour of the things which have been occupying us and concerning us, and also a bit of a view as to where we've got to. And I think the first thing to do is to emphasise, what we have been trying to emphasise, which is that this is the second year of a 3-year process. We're not where we want to be at the end of 3 years, but we are on the route to getting there. And there has been some fairly considerable progress made during this year. There is still a lot more to do. This is a steep path, and there's a lot more to do. But management have grasped that and are doing the right things. Where that's come through in particular, I think, is in the strategic risk management, where we've got a lot clearer on strategic risks in the management process. And the other place where I think we made some pretty good progress is in the management assurance processes, which really weren't there previously. And that, I think, has been very refreshing because The inspectorates are each of them, I think, grasping that they need to take a good look at what they're doing and whether they're doing things in the most efficient and effective way. And I think the two exercises that were done last year illustrated that that they understood that message and they were getting to grips with that. They'll get better at doing it each time they do it, I think, and hopefully, as a result of each of these, there is now a plan for each of the inspectorates about how to improve, and the actions within those plans will be monitored, so we will see whether or not we're making that improvement. And essentially, it is about making sure we do what we're supposed to be doing in the most efficient and effective way we can do it. The other thing to say is that the internal audit arrangements, I think, which are different from last year. I wasn't here last year, so I can't really compare, but from what I gather, I think we feel the internal audit arrangements are a step up and are giving us now a much better feedback. They really only got going in about September last year after the appointment process and planning process. We've now got a full year ahead of us, and I think we will reap the benefit of that, and David and I in particular are making sure that we get the benefit out of that. So I've mentioned the first two areas, strategic risk management and management assurance, already. I'm not going to go through each of the individual areas other than that, but I will just touch on the financial management and reporting bit. I think the first thing to emphasise is that the audits which have gone on here we're not finding fault in the basic accounting, if you like, in the basic bookkeeping, the basic record keeping, and the basic production of the financial statements. In fact, the process for producing the financial statements is remarkably smooth and quick in that respect. What they were finding was areas that needed improvement in the financial management, which is about how the finance function supports the organisation and how the organisation engages with the finance function in actually furthering the business of the Commission. I think it's true to say that they weren't finding things that the finance management team didn't already know about, and Eileen's team were already on top of. And in fact, I think when you look at the procurement side and you look at the contract management side, those were issues which we knew about, which we were already recruiting people into. And I think in the people we've started to recruit or we now have in place, there is a good action plan happening to make sure that we're really getting to do this in a much more professional and effective way than we were previously. Internal audit will go back in the next year and make sure that that's happening. That illustrates again that progress is being made in the financial management area. There's still stuff to do, but it is working there. And I think those are the main things which I wanted to. You talked about the data quality bit already, and I think that was an important area, and I agree. I think so those are the main points that I was going to mention. I don't know whether you have questions.
Thank you, Paul. Do colleagues have any questions for Paul? Yep. Kay.
Thanks for the report, and it's really good to see the progress. I mean, my question is how the committee is going to decide what audits it would like to see over the coming year, and how you make sure that they are the most important and the most relevant ones to undertake. So, sometimes board members get asked for suggestions, but I never make suggestions because I never really know what the priorities are, because, I could make a suggestion, but it might be not worth doing because there are other things. And I just wondered, because I think audit and risk is really important, but I think you need to make sure that it is actually looking at things that are most important and relevant to the organisation and our core business.
Okay. Sorry, I left it on. The way this is done is, and it's a fairly standard way, it's not something which is particular to the Commission, is that the internal auditors will look at developing what are all the different areas that you might have within the audit programme, and that's generally referred to as an audit universe. It's a rather a grand title, but that's what they refer to it as. So they will look at what the if you like, the stock of things is that they might look at. And they will then look at things like the risk register to see which are the highest risk items that are on the risk register. They will look at, they will talk to management about what are the things that management believes are the most important and highest risk areas from their perspective, or that need some sort of look at from an internal audit perspective. So there's a bit of a direction there. They will talk to the external auditors as well about what the external auditors see as being the issues around, and they will come up and they will talk to the audit committee about it, and they will come up with a proposition around that, which won't cover every single area within the universe, but will cover those items which they think are particularly pertinent at the moment, and those items which haven't been covered for some time, so that over a period of time they will try to cover the whole of the universe, but not in one go. So that will form the basis of the initial plan. They will leave a space, if you like, for within their capacity to be able to do things during the year that come up. Okay. And those might come up because, and they might be pointed at those because of something they find. It may be something that management finds, or it may be something that the audit committee decides is important to look at as well. So, for instance, in this year there was not an audit on data quality. That came up before Christmas, basically. Yeah. David and I spoke about that, and we thought this was we didn't just look at it in terms of GP. Information, which was the issue. We brought up that we said, let's go and do this for everything we're doing, because there must be a risk that there's something else in there, and that's where the audit came from on that. Yeah. So that's the general sort of process.
I suppose I was thinking particularly about the data quality, that it came up, and yet it seems really important. And I guess there'll always be things that come up, and it was just sort of to make sure that we are actually looking and auditing at the things that really are most important to us. I mean, it seems a robust process.
Yeah, I mean, there have been a couple of... there was another one around the recruitment processes, which David and I talked about earlier in the year, and that we then got internal audit in. And one of the things we're trying to do is to position internal audit somewhat differently than it's been positioned previously. It has to do what it does basically, but it also needs to be a resource for us that does things which help us with these things.
Just to add to that, so if you look at Appendix 1K, which is effectively last year's programme, we had the problem with recruitment, so we asked colleagues in internal audit to do an audit of our recruitment processes. We know we'd got issues around safeguarding, so that went onto the schedule, as Paul said, about data. And indeed, at the last audit and corporate governance committee, the internal audit team drew attention to the point that we had identified the things that had caused us problems and asked internal audit to go in and look at them again with a view to, had we bottomed the problem, but also was the action that we'd got in place robust and resilient to address the problem. So I think, to Paul's point, we've tried to use it quite strategically where we know there have been issues, so that when you ask executive colleagues questions at our board meetings, we're in a position to be able to answer not just on the work that we've done, but by the fact that we've had internal audit in to actually provide a check and balance. So I think it's an essential part of the leverage we've got. And Jane from the internal audit team, PwC, volunteered this. We weren't soliciting this at all. It was volunteered, and I thought it was a good and fair reflection back of the work that had been done, and just emphasises, I think, Paul's point in relation to we've tried to direct this at where we know there's risk or where we know there's been a problem. So in answer to your question, speak to Paul or speak to me.
Thank you. Appreciate it.
Paul.
Sorry, Michael, may I just add one thing, which is that the work of RGC is an important aspect of the governance process, And what we have tried to do is to look to see what is the areas that RGC should cover and what are the areas that ACGC should cover. In broad terms, there will be overlap between those, but to make sure that there is almost a separate but linked place to look at the issues in our regulatory work rather than in our corporate processes and corporate organisation. So RGC is an important place, and of course we do look at the things which come out of RGC.
Yep, good, thank you.
Thank you. Anna, could you now kindly give us this, very brief update on Healthwatch, please?
So perhaps it's helpful if I just remind what the purpose of this report is, which is for information. I mean, there is not an accountability route for the work of Healthwatch England to the board. So I'm very happy to take any questions on the report, but I would draw your attention to one element, which is in the final paragraph, which talks about Finance and General Purposes Subcommittee and refers to the work that this new subcommittee of my board committee will be doing around procurement, and point to the fact that hasn't started yet. It will happen, it will start on the 1st of July. It represents a move in responsibility for decision making about procurement at Healthwatch within Healthwatch England to Healthwatch England rather than to the current CQC processes. And when David Behan and I talked about that, it seemed that the right place for that to report for assurance purposes, because this is an area where the CQC is ultimately accountable for the way that we spend our money because of the arrangements that have been set up, that should be reported to the board in accountability mode. So in future reports, you will have a paragraph which says these are the procurement decisions that we've approved, so that you can note them. I should also say that actually, I think the biggest contract we've ever procured is about 50k, and most of them are under 5 or 10. So this is not anything of moment and of a scale which would not normally come to the board if it was within CQC. So it's only because we're taking responsibility for this ourselves, which is for us hugely significant and will make an enormous difference, because at the moment, our very small procurements are ending up getting wrapped up in very much larger and therefore much more time-consuming procurements, with the result that our work is experiencing some quite significant delays, which is not helpful. So this will make a huge practical difference to us, and you will get something that won't make much sense, perhaps, in scale, but that's just the explanation as to why.
Thank you very much. Any questions for Anna on Healthwatch? I actually thought that the report, not the last paragraph, but the rest of the report, just showed how helpful it is that Healthwatch is connected strongly to the CQC, because it is this very valuable source of patient and user views. So. And it was a helpful paper in explaining exactly how Healthwatch was organised and structured to provide that. We'll now go on to the final item on the agenda, which is the workforce race equality standard, which is a requirement of all NHS organisations. And Eileen is going to, I'm sure colleagues have seen the various measures that we are going to report, but perhaps Eileen can just introduce the paper.
Thank you very much, Michael. As you say, this is a summation of where we sit today, which we are members of the NHS Equality and Diversity Council, and as such, we've been involved in the development of a standard and an improvement plan, which does require all NHS bodies. We're not necessarily an NHS body, but I think for the purposes of this agenda, it's helpful to be in this grouping. And the first step is actually to get a baseline across the sector of what performance looks like. around how black and minority ethnicity are represented in organisations and some of the issues around that. So on the 1st of July, we'll be publishing the data that you have in front of you. And some of it's not complete because we don't gather data in necessarily the same way as NHS bodies. Some of it is stuff that we think historically we should have been looking for but haven't been, and that we are making changes now such that we can. And some of it we do have comparative data in, and that will allow us to actually understand better what our agenda is. So I think for us, it's true to say it's a very, very important issue to work with. We've already made some small steps, but important steps, in terms of the emphasis that in all recruitment we place upon trying to ensure diversity in our workforce in the recruitment activity we're undertaking currently, and to understand if that's not being achieved a little bit better, why not. We're putting in place a mentoring programme which is particularly addressed to those colleagues who would identify themselves as being part of a BME community, and making that offer available, and very much focusing on the talent pipeline and how that should truly represent the population as a whole. And that is a big piece of work to do, not just for us as CQC, but for the whole NHS community, and indeed well beyond that. So I think this introduces a baseline. I'm giving you some flavour of the importance we place upon it. There is a question here for the board. Our previous chairman was very involved with this agenda and chose to be the board representative and champion on this matter. So really looking to the board to think about, perhaps not today, but in the future, whether in the short term it would like to identify who would be the board representative. In most organisations, it is most usually a non-executive who picks up this championing role. It doesn't necessarily have to be, but I put that out there. And it also asks a question of us in terms of how representative we are as a board, which is, of course, if we look around the room, we may conclude not wholly. And then beyond this, and I'm sure that the work of the Equality and Diversity Council will get into this. Just as we catch up with this agenda, there are whole new agendas emerging in this area around how people are defining themselves in ever more complex ways, and that the notion of BME is in itself being held in the diversity community to be becoming somewhat outdated. So we have to play both catch-up but also forward-looking in terms of understanding people, understanding the support they need, and understanding how people define each other. So I hope that gives a sense of the work that's ongoing, Michael. The questions asked there are to alert you to the publication of the data on the 1st of July, to ask for everybody's engagement with this particular agenda. It is crucially important. We need to be able to draw on all the talent, not just a segment of it. And to then ask the board to consider who it might like to have as its champion on this.
Thank you very much, Eileen. I think let's take whether the board approves the submission of this information. Our colleagues happy that we do that. I think on Eileen's second point about a board champion, I think that is it is an excellent idea. Can we, unless colleagues have an objection, can we do as sort of first step, anybody who'd like to volunteer to undertake this role of being our diversity champion, just send an email or call Eileen, and Eileen and I can then have a discussion, if depending on the number of volunteers we have, and of course the more volunteers the better. How we might have, how we might choose amongst the volunteers. If we have no volunteers, of course we've got another problem, and we'll have to discuss that too. But so I think, in the first instance, I think it's far better for individual board members to express to Eileen their wish, or to become our diversity champion, because I think it's right that that's an important role for a non-executive to hold. Good. Well, that brings us to the...
Michael, can I just add one point about not in terms of CQC, but in terms of the NHS? This will be an extremely valuable information to us when all NHS bodies do publish it. We've already been doing some work internally on the metrics. 4 of the 9 metrics come from the staff survey, and I spoke at a BME conference quite recently and presented some of the preliminary findings from that. But what it will help us to do is to identify organisations, trusts in my case, where there is a big gap in the response rates, particularly on questions like bullying and harassment, between the BME community and the white community amongst staff. So we will incorporate this into our inspection process.
No, I think that's very good to hear. I think, as colleagues will have seen, I think the only worrying indicator here was, whether or not BME staff, and I'll continue using BME for the moment, feel they've got an equal opportunity in career progression. But I think there is an action against that item. For the rest of the indicators, I thought that it showed the CQC was very responsive to the various ethnicities of the colleagues that the CQC employs. So thank you, and thanks to Mike for that too. Kay.
I think we do actually have a vacancy on the board now, I think, and it is very white, and I think we really do need someone particularly that can champion race. I mean, there's diversity, which is fine, but I think the sort of race issues are really important, and we don't reflect the population we serve. So I think we should look to be recruiting in that way, hopefully as soon as possible, really.
No, very good point. Any questions from our visitors or our attendees? Yes, and perhaps you can, because of this being going out on YouTube, just identify yourself for the wider public. Obviously, everybody in this room knows who you are, but I think we have quite a few thousand people watching this.
Well, my name is David Hogarth. I had the pleasure yesterday of attending the Health and Care Show in Docklands, and I heard Andrea giving a brief, excellent talk to the home care section of it. In the middle of it, she produced a slide showing the proportion for each domain of for each different rating, the outstanding, good, requires improvement and inadequacy. And she particularly drew attention to the caring domain and to her own directorate, because there were a very small number of failures in the caring domain and a very large number of ratings that were good. What I would take issue with is that she then celebrated this, said that this is a wonderful thing. Well, of course, if it is true, it is a wonderful thing. But what I would suggest is that do you really have enough evidence to say that this is true? Are they really good? And I would say that without some, I suspect you rely mainly on reports from users, which the users who are least likely to be well cared for can't report, and a lot of people won't report accurately on it. You don't use cameras. You don't, in particular, use sound recording devices, which seem to me particularly suitable for the caring domain, insofar as that is a question of kindness and compassion. You don't need pictures. You don't need the problems of privacy if you have, and you don't have the problems of privacy if you use sound recording devices. And I have said, of course, all these things before, but it seems to me that before you start celebrating the excellence in the caring domain in adult social care, you need better evidence.
Thank you, Andrea. I think the charts that you refer to are charts of the findings after inspection. So they're not data, well, you know, there is data behind them, but there are also our new method of inspection behind them.
Thank you very much, Michael, and thank you, David, for the question and the compliment. But Michael's absolutely right. What we're showing there are the 5 questions that we ask and how they appear after our reports have been published as to whether services are inadequate, requiring improvement, good or outstanding. And I guess that kind of the central point of your question is the evidence good enough for us to make that judgment? And it won't surprise you to hear me say that I think it's pretty good. Clearly, we could always do more, but I think that we have established a new inspection regime which, both through the monitoring that we do in advance of the inspection and particularly in responding to concerns and issues that may have been raised, sometimes directly with us, sometimes anonymously with us, about concerns that allow us to focus on particular aspects of care on the inspections that we do. When we're on inspection, we spend a lot less time one of the care home managers described it as we spend less time turning right into the office and spending more time turning left into the actual service, and spending time with people who are using the service and spending time speaking with them and their relatives as well as staff. The other thing to say is that what we also do is observe, and it's sometimes quite astonishing to me the sorts of things that my inspectors do see on inspection in terms of the interactions between care workers and the people that they are caring for and supporting. And that's either because they don't know that the way that they're doing it is inappropriate, or that they do know and they don't care, and they certainly don't care enough to not do it in front of inspectors. So we do uncover quite a significant level of insight. We also are increasing our use of experts by experience in our inspections, and these are people who have had a personal experience of care. And they are fantastic, frankly, in spending the time to speak with people about the care that they're receiving, how they're treated, how they feel about that, and really getting a tremendous insight from them. And I think that they really do help us to get a good sense of the caring nature of the staff. The other thing I would say is that we also get quite a bit of challenge around that. We do represent in our reports the issues and comments that are shared with us by people who are using services and their relatives and carers. And we have had challenges about that, and we have had challenges from providers saying, well, why are you believing anything that anybody says because they've got dementia? Well, I will defend to the hilt our responsibility to talk to people, to understand from them as best we can what their experience of the service is. And if you spend the time properly and if you do it well, you can actually understand what their experience is. So I'm sure there are things that we can improve over time, but I am pretty confident that what we're seeing at the moment is a good reflection. But as I also reflected in the actually the 3 things that I did yesterday, was that we do see a lot of caring, but sometimes that's despite the system. And that's a real problem. And we need to make sure that we're addressing all of the other questions as well, because we run the risk of really good caring staff getting burnt out and leaving the sector.
Thank you.
I think the important thing here is two things that can seem in contradiction. One is I think the board consistently is restless in searching for more information. And I think we will never be satisfied that we've got all the information, all the different forms that we've got. So there is a quite an openness and a restlessness for that. And I think that's an important stance rather than closing up and saying we know everything. Mm-hmm. But the second thing is, which is much tougher in a way, is we have a duty to make judgments around the information we've got, whatever the information we've got. And so these two things can appear to be in contradiction, but actually the duty to make a judgment is a crucial part of what Parliament's asked us to do. And if we don't make that judgment, no one will make that judgment. So I think, and the two things is to actually for us to know we can always get more information, we can always listen to people better, we can always search out information, but actually the information we've got, you and we have all got to make a judgment about.
Good. I think there's another question.
Thank you, Chairman. Robin Pike, Healthwatch, Hertfordshire. Two questions, if I may. One concerns public engagement. I wonder how the board feels, or whether the board feels that members of the public generally understand the Commission's inspections and their processes, or whether they merely rely on reports in the Daily Mail and the Times.
Well, why doesn't, and this is a very intriguing question, incidentally, we touched on it in a way with NHS 111. My own view, for what it's worth, is that we should be telling callers that the CQC is ensuring that 111 services are very good. And it is an opportunity for us, at the beginning of this telephone call, that is after they spent whatever time it is waiting for the call to be answered, to actually explain that the CQC is investigating, inspecting this service. So I think communication of what the CQC does is very important, but I think this is probably a question for David.
Oh, right. Never believe what you read in the newspapers, Robin, but anyway. No, I think a substantive part of what we've done over the past 2 to 3 years and previously is to build our work on the experiences of people that use services. I think this goes to David's last question as well. We're just about to re-tender the contract for Experts by Experience. We've given that a fair degree of scrutiny, quite frankly. I think Kay's been involved in some of those conversations, as has Anna, to make sure we get that right, so the voice of people using services is in. And about the balance, we were just talking about this yesterday, about 95% are people that will be on inspections. The other 5% is where we use them when we're developing new approaches, new methodologies, new policies, etc. So we've got that in. The language we've used and increasingly use, and I think increasingly will continue to use, is of co-production. Is about doing things with people, not doing things to people. And I think if we want to claim, as we do in our literature and many times in conferences, that we are on the side of people that use services, then we need to demonstrate that through what we do. I think we can make this statement again. Anna's running her, here's the advert for you, Anna, a Healthwatch conference nationally next week in Manchester, and both Andrea and I are going to go and present and listen and participate. I've got the kind invitation of actually going along to the Healthwatch's awards ceremony. I don't know whether you're up for one, Robin, but anyway, tune in on Tuesday evening, we can find out. And that will celebrate some of the successes of engagement and the signposting. I think this picks up on your question, Michael. And I think that's where we go to. I personally am interested in what the Times has got to say. I'm interested in what the Mail has got to say, but I wouldn't go to either of those newspapers to find out how we should do this and what the voice of people using services actually is. I think Paul's point about restlessness and having to arrive at a judgment is well made, actually. I think we should never be satisfied we've got the right way to do this. We should be constantly restless of how to do it. But the truth is we've got to judge the quality of care. And increasingly, when I'm out and about, people tell me, I looked at your reports and it helped me choose a home for my mum, my dad, my uncle. And we get complaints where I chose a home and I don't think you were right. And I think that is the currency we've got to deal with. That is the job we've been given. And that is, I think, why we need to constantly be restless about getting this right. But let's go to those conversations, the authentic voice of people using services, not what somebody sat just down the road in Fleet Street is banging out this now, as important as that is, or metaphorical Fleet Street.
Thank you. I think we've got time for one more question. Well,
thank you, Chairman. This relates to inspection of primary medical services. I understand that currently the notifications of individual practice inspections are received by CCGs 4 weeks in advance and by the practice 2 weeks in advance. Would it be possible to notify local Healthwatch and also local patient groups of the inspections in advance and possibly patient participation groups?
A good question. Steve?
The answer to the question is we give advance notice because we don't want to add to the bureaucracy and disrupt the practice on the inspection. And my understanding is in most areas there is communication with local Healthwatch on an ongoing basis. You'll see increasingly as the year rolls out that we're inspecting everywhere across England, and so actually what we need is a continual dialogue with local Healthwatch rather than just this week or next week, and that's what we encourage, very much so. As far as patient participation groups go, most of the practices that we go to, we do find there is dialogue with patients. But sadly, in a few, they still do not have patient participation groups, and that affects our rating in well-led. So we encourage dialogue with service users all the time.
Yes.
Can I just so it's a good question, but I think our from Healthwatch England's perspective, when we've spoken with local Healthwatch, there's a real sense that emerges from the network that the way in which they're engaged with the CQC inspection process needs some management, if you like, because if they were actually kept abreast of in advance of all of the different inspections which are happening within their area, sort of across all the different sectors, it would become perhaps a. I mean, I think they wouldn't be able to respond to them all. It would potentially, their concern, kind of divert them from some of the other work that they need to do, because they need to choose where to become involved and where not. As we know, local Healthwatch have relatively scarce resources and need to prioritise really, really carefully. So what local Healthwatch have said to us is that because of the scale of hospitals, it is absolutely useful to be kept abreast of those inspections. For some, that's more of a burden than others because they may have more than one in their area. But for many, it's more manageable. But in relation to primary care and social care, it's much more helpful to have as Steve has suggested, a periodic engagement about what is known about all of the practices or all of the social care facilities in an area, rather than to have that in relation to every pre-planned inspection. So. I think your route is a different route, but actually local Healthwatch are wanting this kind of managed in a slightly different way, in my experience.
Good. Well, thank you, everybody. This brings the board meeting to a close. We're now going to have or the non-executives are going to have a very brief break for coffee, and the executives will have a chance to check their BlackBerries, phones, or whatever, because we're going to have a very brief session with the non-executives together. I mean, this is absolute, by the way, this is absolutely standard in under UK corporate governance rules. There's nothing special about it. But given again, in terms of NAO points, they did make a specific point about board development. So, so we are going to have this brief session today because it is recommended in the governance code that happens, and the whole board will then reassemble for our next meeting at 11. Thank you.